Good afternoon. My name is Dr. Sarcar. I'm a fifth-year neurosurgery resident at Michigan State Henry Ford. Today I'm going to be talking about the effect of low-dose Ketorolac on minimally invasive transforaminal lumbar interbody fusion patients. This is a final analysis from a randomized, double-blinded, placebo-controlled trial of note. Previously, we have published on initial protocol as well as a interim analysis halfway through mark, or at the halfway point. Of no conflicts of interest. So as the ongoing opiate epidemic continues, clinicians are often looking for ways to avoid opiate medications altogether. However, there's a certain population of patients or clinical scenarios in which you require opiate medications, such as in the postoperative period. This has led a lot of clinicians to find different ways to at least reduce the opiate load, often using NSAIDs, including Toradol or Ketorolac. Interestingly, Ketorolac has been shown to have a much higher rate or a much more potent effect on pain control as opposed to its anti-inflammatory effects, which makes it a unique among NSAIDs in terms of possibly treating postoperative pain without some of the negative side effects. Nonetheless, though, there's still large concerns with using Toradol in postoperative patients, particularly postoperative fusion patients, in terms of getting increased bleeding risk as well as the possibility to decrease fusion rate. The objectives of our study was to evaluate the safety and efficacy of short-term low-dose Ketorolac following MIS TLIF, particularly looking at patients' fusion rate as well as postoperative opiate usage. The methods, this was a randomized, double-blinded, placebo-controlled, non-inferiority trial. The patient populations were adult patients undergoing MIS TLIF 1 to 3 levels from October 2017 until 2024. Exclusion criteria essentially can be broken down into 3 groups. The first group is patients that had an increased risk of pseudoarthrosis, such as patients that were on high-dose steroids or smokers or patients with autoimmune diseases. The second group were patients that could not tolerate Toradol, particularly those with chronic renal disease. And then the third group were patients that were undergoing the fusion for non-degenerative reasons, such as tumor or trauma or infection. Outcomes, our primary outcome was radiographic fusion at several different time points, 6 months, 12 months, and 24 months. And secondary outcomes included inpatient MME, length of stay, and several patient-reported outcomes. Overall, we assessed approximately 2,000 patients for eligibility, and with that group, 420 were ultimately randomized. They were randomized on the day of surgery into one of 2 groups. The first group was our treatment group. They received Toradol 15 milligram every 6 hours from PACU until 48 hours post-op. And then the control group received a similar pain regimen, except instead of receiving the Toradol medication, they were given a saline solution. After follow-up period, we were able to, primary analysis to assess fusion, we were able to obtain 139 patients in the treatment group as opposed to 148 in the control group. So again, of the 420 patients that were randomized, 355 were able to be analyzed, 167 in the Ketorolac group, 188 in the control group. The baseline demographics and operative characteristics between the 2 groups were essentially comparable. The fusion rates did not significantly differ at all 3 time points, 6 months, 1 year, and 2 years. And the interestingly, or on a positive note, the mean total inpatient MME as well as the 48-hour MME was significantly decreased in the Ketorolac group. There were no significant differences in the overall complication rate, revision surgery, or long-term patient-reported outcomes. So this table is just showing you there's no significant difference, again, in the baseline demographics, no difference between the preoperative PROs and the operative data was similar. Table 2 is showing fusion outcomes per interspace level, and you can see at all 3 time points, 6 months, 1 year, and 2 year, there was no significant difference in terms of patients that had solid fusion, probable fusion, or non-union. This figure is just showing that showing the non-inferiority rate with everything to the left of the red dotted line being considered the zone of inferiority. You can see that none of the horizontal black lines at all 3 time points showing the difference between the fusion rate between groups crosses that, showing there's a non-inferiority of Ketorolac. Again, in terms of perioperative PROs, the total MME and 48-hour MME, as well as the length of stay, was significantly decreased in the Ketorolac group as opposed to the control group, and the postoperative VAS was significantly improved in the Ketorolac group as opposed to the control group. There was no significant difference in complication incidents, surgical revisions, or disposition. This figure is just showing the average MME based on postoperative day, and all three groups, you see there's a significant decrease in the number of MME in the Ketorolac group compared to the placebo. And again, this is just a VAS score shown over several time points in the postoperative period, showing a significant decrease in the VAS score in the Ketorolac group compared to the placebo group. So in conclusion, short-term, low-dose Ketorolac following MIS TLIF is not inferior to placebo with respect to fusion rate throughout 2 years, and provides significant reductions in early postoperative pain, opiate consumption, and hospital length of stay without significantly increasing overall complications. Incorporation of Ketorolac into multimodal analgesic protocols may offer a safe and effective opiate-sparing strategy in lumbar fusion surgery. Some limitations, and probably the biggest limitation in this study is the external validity, being that we use BMP in the interbody space. There are a large number of people who don't use BMP, and the question to ask is, without the addition of BMP, would the fusion rate still be similar?
It has long been appreciated that NSAIDs have the potential to reduce rates of spinal fusion. The inhibitory effect of NSAIDs now is appreciated that it is additive to what can happen with opioids. Opioids inhibit vascular endothelial growth factor A and impair angiogenesis, and so the use of opioids is an additional concern when administered along with NSAIDs. In this particular model, in this paper, they demonstrated that the combination was detrimental to fusion rates, more so than just with the NSAIDs. The specific NSAID in that study was Ketorolac. There has been to date, there is no level 1 evidence from human studies regarding the use of NSAIDs and their effect on spinal fusion rates. Their use at less than 2 weeks has not been shown to lower fusion rates, and a 2-week course is shown to have a dose-dependent effect on fusion rate. A 48-hour course of NSAIDs has not been shown to lower fusion rates. This is all retrospective cohort, so on and so forth. It's level 3 information. We don't have level 1 data on this particular topic. In this analysis, basically looking at NSAIDs and opioids, it was shown that increased consumption of narcotics in the perioperative period was associated with greater mortality, higher rates of readmission, and pseudoarthrosis at 365 days. This study shows the non-inferiority of a short course of Ketorolac, and its effect does not negatively impact fusion rates. This slide is erroneous, I apologize. This study does not provide level 1 evidence. That would require multiple prospective randomized trials, as you all know. This is level 2. It's a prospective randomized study, and the study essentially probably marks a milestone in moving the science forward in the effect of NSAIDs in the early postoperative period. The authors are to be commended. Thank you.